Good morning. My name is Lisa Cordova. I'm the manager of 6 North, and I'm also a member of the Zero Harm Committee here at HCA Northwest. As a new member of our team here at Northwest, we want to give you some training into nurse-sensitive quality indicators, NSQIs. These were identified by the National Database of Nursing-Sensitive Quality Indicators, NDNQI. First, NDNQI is an organization created in 1998 by the ANA to gather as much information as possible that was specific and sensitive to nursing. By collecting as much data as possible, they could show how the facts they gathered could influence and improve patients' quality of care with a specific type of nursing. Press Ganey acquired the company in 2014 and manages the data now. The data is used to drive change based on specific data with validated evidence, the start of evidence-based practice, Tomaskia 2022. Press Ganey also validates practices with patient satisfaction scores. It can be reviewed by the organization to look for opportunities for improvement. Nursing-sensitive quality indicators are divided into 3 categories. Structure quality indicator is the quality of the healthcare organization or its clinicians. It focuses on the characteristics of the organization, their staff, and assesses the delivery of the services within the practice based on its quality of service. Process quality indicators assess the quality of an action provided to the patient. These actions are led by evidence-based practice. The last category is outcome quality indicators. It breaks down the types of outcomes by population, and it looks at health statuses, psychological illness, falls with the injuries, for example. The idea of this practice model is that the organizational structure have a workforce that puts into place processes which can affect the healthcare outcome. Thomas Hawkins et al., 2017. By using this model, data is gathered by the organization. Current processes are in place based on current evidence-based practice. The outcome data is recorded. If the outcome data is positive or negative, it is still recorded. If the process or practice is negative, then a new practice may be used, data collected, and data reevaluated for improved outcome. If outcome data was found to have improved or current practice is positive, that data will be entered and validated. The best practices and outcomes affect our patient satisfaction scores. Those scores can be used to guide the opportunities for education or changes in our practice or to validate our current practices. For this, I have decided to do this tutorial to focus on CAUTI, or catheter-acquired urinary tract infections. CAUTIs are the 4th leading cause of HAI, hospital-acquired infections, in the acute care setting. 13,000 deaths are attributed to CAUTIs per year, and the second highest reason for sepsis, Ferguson 2018. CAUTIs, or lack of them, are important indicators of our infection control practices. It is also an indication of patient safety. It can drive patient satisfaction scores down. If a patient comes into the hospital and has a Foley catheter inserted and develops an infection, we would have some opportunities for improvement in our current practice of maintenance of Foleys. The best practice is for education of all nurses, both new hires and annual, to refresh us and to get the latest evidence-based practice and care. The reason that I chose CAUTI is because on my medical surgical telemetry floor I manage, we have had 3 CAUTIs identified on my floor in 4 months. I had a root cause analysis done, meeting with the infection prevention director, my medical director, CMO, the primary nurse that day, and a member from the lab. We reviewed the patient's file and looked at any opportunities for improvement that could help prevent HAIs in the future. The evidence-based change model was used to identify any issues and find interventions that would have better outcome. We review specific practices and how the IP director gathered the data to assist in the investigation of the event. Hand washing compliance was checked for my floor. The scores were from data entered by myself and secret shoppers to document the practice of hand washing in a program set up by the Joint Commission. My floor was 93% compliant. She looked at CHG documentation. found that in our report mark with our data from the electronic health record entered by the nurses. There were opportunities here. When a patient has a Foley, the documentation of the Foley must include the CH bath and peri-care given during that shift. My nurse had been compliant on bathing and charting it. However, a report on my floor showed others were not. It is not only important to do the bath, but to make sure it is documented. She also looks for the reason for the Foley, the indication. This investigation must be done by looking through the chart itself, looking for a urology or nephrology doctor following the case. Other report from the lab, assuring that the collection of the specimen is done appropriately and is validated by a ticket to ride, TTR. It validates proper cleansing and collection of the sample, appropriateness of the order, and timeliness of the sample sent. All validated through the lab documentation, label on the sample, and another staff member confirming correct collection of specimen on the ticket to ride. If any fallout of practices are found, managers get reports daily for review. We usually will reach out to remind you, the staff, or education if needed to assure compliance of the best practices and maintenance of Foley. Another practice followed is indication for the Foley itself. Initial indication, sometimes it changes or the nurse was not sure. When you get report from your previous staff, ask why the Foley is in. Another, if they are not sure, read through the notes for the indication. If there is no longer an indication, be an advocate for removing that potential for harm, Ferguson 2018. If it is indicated with following neurologist, nephrologist, or urologist, ask when they make their rounds if avoiding trial can be done. In prevention of CAUTI, education of the staff is so important to prevent. In prevention of CAUTI, education of staff to prevent is the most important. Sorry. You are the front lines for preventing this type of infection. First, asking if this is necessary. Is there an order? Look through the chart for indications. If not clear, ask the physician for avoiding trial. At our facility, we have nurse-driven Foley removal. If indication is missing, it can be removed. Second, assuring proper maintenance is done and documented. Next, using the green clip to assure that the Foley is in line and clipped to the sheet, no loops or stagnant urine in the line that could go back into the bladder and cause infection. Lastly, if needing a urine sample, use that ticket to ride to assure the sample is appropriately collected and for the right reason. If you can start your practice with a keen eye for patient safety, we can achieve great things, and our patient will have the best outcome with evidence-based practice used to get us there.